Thank you, and welcome to the first annual Mark Fear Lecture on keloid pathogenesis. I'm looking forward to this lecture, but I also, it brings some sadness too. I think that Fiona will talk a little bit about Mark. But today I'm here to introduce Fiona Wood. It's my great honor and a privilege to introduce our friend and esteemed colleague, Fiona Wood. While many of you may know her as a scar researcher and surgeon, you may not be aware of her contributions to the burn field. Fiona's dedication to improving outcomes for burn patients began when she was trained as West Australia's first female plastic surgeon. She quickly became a leader in her field due to her surgical skills, ability to lead, and her ability to direct innovation for future clinical care. Early on in her career as a burn surgeon, she recognized the potential for using cultured keratinocytes to heal wounds. But growing keratinocytes into sheets that can be grafted to wounds takes weeks and requires specialized facilities. Recognizing that something better was needed, she developed a device to spray keratinocytes onto wounds to heal burn wound healing and improve patient outcomes. This device, now known as ReCell, allows burn surgeons to take a small skin biopsy in the operating room, digest the tissue within just a few minutes, and then spray the cells back onto the wound without the need to culture cells and without the need for specialized facilities. This helps burn wounds heal faster and with less scarring. And that device is now used widely throughout the US and all around the world. And I think, as you heard yesterday, and we'll hear again in a few minutes, she remains passionate about improving the outcomes for patients and continues to innovate. She founded the Fiona Wood Foundation, a nonprofit organization dedicated to advancing burn research, treatment, and prevention. In recognition of her tremendous contributions to the care of burn patients, she was named Australian of the Year in 2005. Not only that, but she was voted Australia's most trusted person for 6 years in a row. And also, she has been recognized as an Australian living treasure. And I think if you know Fiona, I'm sure you will agree. We welcome her to Amsterdam this week to talk about keloids, and we thank her for sharing her knowledge with us. Thank you.
Well, thank you so much, and trust me, I'm a doctor. So it is with enormous pride and enormous sadness that I'm going to share with you some of the work that was very dear to Mark over the next 30 minutes. Mark was one of a kind. His brain, the size of a planet, would put up with me on regular occasions when I came up with ideas that were so crazy, but he made the magic happen. As the senior scientist working for almost 20 years, it's a relationship that I will never have again. And so here we go. This is some for Mark. I mean, scars, we know, impact a lifetime, and these images all represent discussions with Mark. He was fascinated by the young girl burnt in Vietnam. That she could improve decades later with laser. Our patient, Ben, whose small accident left him with a lifetime of care, needing a lifetime of care. And so looking at fibrosis across the board was where we had a significant interest, trying to understand the molecular and cellular mechanisms. Can we drive repair such that we can promote regeneration, such that we can reduce the scar outcome across the board? All scars, all fibrosis. Our research in Western Australia is focused on reducing the long-term impact of specifically burn injury, physical, psychological, and physiological. It's in 5 streams, and Mark was fundamental to each and every stream, looking at skin regeneration and healing for one area we've been known in for many decades, looking at the skin chemistry for diagnosis and prediction of outcomes, unscarring the scar, which I'll come back to because that's the tribe we're in here today, and looking at the systemic impact of trauma and the neurological response. And one of the focus items of our work has always been an education and training program to translate to the bedside, thinking about what is the problem that we're facing, how can we bring that basic science to bear, and how we can actually collaborate broadly in order to actually make that science work. And so we know that skin is abnormal in its chemistry, its architecture, the mechanobiology and the cell phenotype, whether it be fibroblasts, keratinocytes, the immune cells, all provide opportunities for intervention, opportunities to understand so that we can then potentially drive a repair as a regenerative repair rather than the scar repair. And I think the other philosophy that we've driven very hard is that every intervention from the point of injury, from the point of trauma, from the point of, whether it be trivial or not, that will drive that scar for life, every intervention can actually make a difference. And so understanding the science and the evidence base around the whole inflammatory pathways. Inflammation is essential for healing, but too much drives that scar outcome. Understanding edema control, infection control, gives us an opportunity to interrogate the science and then change therapy, embed in a model of care, and drive forward with incremental gain to continually reduce scar outcome. One area that is particularly important to us is trying to understand regeneration. I mean, if we understood regeneration, would the keloid disease paradigm just be no longer? I mean, there's a thought. And so when we start to look at different animal models, and you look at the comparison here between an axolotl and a mammal, you can see rapid epithelialization is associated with a reduced inflammation and earlier remodeling and a regenerative repair with no scar. What can we learn from that? And one of the hallmarks for Mark was insatiable curiosity. What can we learn from wherever we look? And so one of the areas that I think brought us to this table some years ago, I think it was in Montpellier, was understanding that clinical impression of a scar is dogged this field. Because a lot of what we see presented and published in the literature is a mishmash of keloid, of hypertrophic scar. And so what is true recurrence? And I would suggest that true recurrence might well be close to 100% without really dedicated therapies and actually thoughtful therapies. Understand, we've got to treat because we've got people suffering right here, right now, and treat the best we can, but we've got to interrogate the underlying mechanisms. But first up, we've got to make the diagnosis. And so we started looking at things like methylation patterns, and we saw that the methylation pattern in a keloid was significantly different from a hypertrophic scar. And when we start to look at single-cell sequencing and all these different things, can we actually facilitate a diagnosis right from the outset? One of the things that we've been working on is trying to make the diagnosis not just requiring punch biopsies and expensive technology with methylation and so forth, and epigenetics, but what can we learn from the swabbing the surface of the skin and looking at lipidomics and proteomics? Can we infer from the surface the pathology underlying the skin? Now there's a thought. Maybe someone can pick that up and run with it as we go into the future. We know that the keloid fibroblasts have got a distinct transcriptome. We can see here, when we look at the keloid heat map from the keloid versus the normal fibroblasts here, we can see significant changes in the regulatory pathways. So, and what are those pathways? What pathways are they? What do they involve? Which cell types do they involve? All these things are things we need to understand and know. And we also need to understand and take that into the sort of the physical side of things and understand the molecular and cellular characterization so that we can strengthen the diagnosis. We've seen, we look at normal fibroblasts, and they respond to stiffness of the culture, the medium they're grown on. But interestingly, the keloid fibroblasts appear to be unresponsive to the stiffness cues. What pathways are involved there? how can we actually use that information to increase our therapies? We've seen over the last couple of days surgery to offload pressure and stress in the tissues, leading to an improvement. Whether it be the laser, the punch biopsies, the introduction of new tissue, all those things change the characteristics of the stiffness across the surface. So we can use that information, but how do we take that further into understanding the pathway analysis lying behind it so that we can actually then drive novel therapeutics? The fibroblasts express different cell markers. This is just CD26 positive cells, and we've been exploring flow cytometry. I know I'll have to invite Lucy to come and speak with you next year in Paris. But we know that they express different surface markers, and therefore we can identify them. How can we use that information? How can we use that information to understand the processes and also to block them, to block the processes, to actually block the scarring process. TGF-beta has been a long time around the traps and trying to understand how that influences stiffness. And certainly in our space, where we're looking at the tension, we know reduces scarring, but there seems to be a lack of sensitivity to TGF-beta. So what is that? What's happened to that pathway? Is it become overwhelmed? Is it blocked? Is there alternative pathways with respect to the cues for stiffness? Then we look at the other major cell group in the scars, and of course that's the keratinocyte. And again, we can see very different heat map with the keratinocytes from keloid scars versus keratinocytes from normal skin with no underlying scarring. Using this information is a starting point to drive us forward in our understanding. And when we start to see what genes are highlighted, are upregulated and downregulated, we can see that there's a lot of inflammatory pathways, but also pathways involved in barrier function, and hardly surprising because the epidermis provides us the barrier. But let's have a look at some more detailed work around this space. And this is looking at the analysis where we've looked at the dysregulation of tight junction genes related to the keloid keratinocytes, and we can see that they are impacted. So that the tight junctions are not performing as we would expect. So looking at the distribution of the tight junctions across, when you look into normal skin, you can see the stain, you can see those cells are tightly packed. You can imagine there's a very firm barrier there where you look at the keloid and they're sort of spaced out. What's happening here? Why do we not have the development of an epidermal layer, of the keratin of that epidermal layer that has an integrity that is equivalent to normal skin? And is it the disruption of this barrier that actually facilitates the ongoing stimulation of inflammation? So things like the microbiome, it may not be a cause, but it may be an opportunistic bystander. It may not be causing this change in barrier function, but being presented with a disordered and deranged barrier, then it's an opportunistic player that drives the ongoing inflammation and continued stimulation of the immune response within the skin construct. An area for further investigation. So in summary, so far, we've seen that we've got an altered barrier function of the keratinocytes, but the keratinocytes actually do interplay with the fibroblasts. And there's work from Aziz Galhari presented this a long time ago. We know that there's changes in the keratinocytes in keloid, in the fibroblasts in keloid, in the immune cells. There are changes in the transcriptome of all these cells. And as we've chased down and looked at what is disordered, we've seen the barrier dysfunction, and we've seen that as one aspect. And the tight junctions are abnormal, are dysfunctional. And so it's really interesting because I think what we're dealing with is a disease that is so complex. This is just one small aspect. But when you look at the science and the endeavor to get to this point behind one aspect of this, it is not trivial. And so where do we go from here? One thing Mark really contributed was bringing that science and that understanding, the basic information, into our clinical arena. We've spoken a lot about a laser, whether it's good, bad, or ugly, over this last couple of days, and I should suggest to you that laser isn't laser, isn't laser, isn't laser. And there is, to my knowledge, to this point, the fractional laser dosage relative to thickness has not been interrogated in a way that I would put my hand on my heart and say, right, this scar is X thick with respect to the epidermis and dermis, therefore this is the dose of laser required with respect to the penetration and the area, surface area of the microthermal zones, yeah? So what is happening? We're seeing variable results because there's a level of random motion going on here. We've got to put a laser in the hands of a clinician who sees it benefit people most of the time in certain circumstances. This is hypertrophic post-burn scar. It is very positive in that space for most of the people, most of the time, but not all people, all of the time. So we've got to do better. And so the doing better is where Mark comes in. And we started looking at trials where we actually took punch biopsies and started looking at the histology and trying to investigate how we could understand the changes in the biopsies from a structural tissue perspective, as well as taking the cells from that tissue and going down the cell biology perspective as well, and then looking at what those cells produce. Lots of work that I haven't got the time to go into, but we've got to take biopsies. Well, that's actually destructive. And so one of the other hallmarks of Mark was collaboration, and collaboration with other people. And so this is a team we connect with, and we're sort of kind of joined at the hip with now, our biomedical engineers with optical coherence tomography. And we can see here that the vasculature can be identified and tracked over time without biopsy. So this is a way of getting information from what we're doing that can be quantified without taking the biopsies. And so starting to understand what technologies are out there and how we can use them is so important. And this is another setting on the dial, if you like. We've looked at the vasculature, but we can also look at the collagen and the birefringence of that collagen, whether it's a normal characteristics or it's abnormal. And we can track it over time. And so that without taking physical biopsies, we can see a bigger surface area of change as well. Because, of course, a biopsy is only where that point is. And so by collaborating and moving outside the cell biology into the engineering, we're able to improve what we can see and expand our knowledge even further. And so that is something that, I think is gold, really, and something we can't walk away from. We've got to know what is out there and how we can use it. We've heard about the imaging, whether it's thermal imaging, spectral AI, all these different kind of imaging. We've got a team at home that's worked on elastography and put it on a smartphone. So all these things we can start to bring together, bring to bear for our patients so that we can understand the impact of what we are doing, so that then we can actually do better. Because I think that's the bottom line I should have said right at the beginning, was the absolutely overwhelming thing that brought us to this table was the need to do better to reduce that suffering. And so Again, understanding skin. Yeah, I often use a slide what a beautiful thing is skin. It helps to keep the body in. That's Spike Milligan. Yeah, and where do we go from there? I think because it keeps the body in, but what else does it do? How does it turn over? And one of the pieces of work we've undertaken was trying to understand. We know that the epidermis turns over every 6 to 8 weeks, depending on how old you are and how it's stimulated. But what about the dermis? And so Mark saw this work done in liver fibrosis with use in heavy water, the hydrogen bond between the collagen fibers, therefore it has the heavy water, therefore it can be identified, and with the dose of heavy water over time, you can measure the turnover in the liver. We thought, well, can we do that in skin? And so it was the first experiment. I'll have to shoot you all once I tell you this. One of us had to drink the heavy water and one had to take the biopsies. And all I can say is I took the biopsies. And so we saw over time that this was possible. And then we got appropriate ethics and went on to look at metabolic tracing with heavy water in established scars. And our first 5 patients with a significant age range, we were able to take punch biopsies in scarred and non-scarred areas where during the time they were drinking the heavy water, and then using mass spectrometry, we were able to measure the concentration or the dose, if you like, of the hydrogen bonds in the different collagen fractions. And so, this is the patient, so you can see the red is the scar and the blue is the skin. And in all cases, the normal skin, the non-scarred skin, and in all cases, the non-scarred skin turned over faster than the scarred skin, but also age mattered, and the turnover gets slower with age. And so we start now to have an understanding of that turnover of the dermal elements, a turnover of extracellular matrix. Therefore, there's an opportunity for therapy. Yeah, we've now got an understanding of the time frame that will take. And so we know also that there's the density of that collagen is what's driving the stiffness and what's driving the scar. And it's whether it's a chicken or egg, what actually starts and triggers that process, I think we've still a long way to go to find out. But once it's triggered, it is a vicious cycle with the phenotype of the cells laying down the collagen becoming abnormal in its hydrogen bonding, getting stiffer, driving a stiffer phenotype, making it favorable for that fibrotic phenotype of the fibroblast. And so, well, what's doing this? And so we started then to look at lysyl oxidase. And so if we had a LOX inhibitor, could we break the hydrogen bonds between the collagen fibers such that we didn't have that progression into the scarred extracellular matrix that was driving this increased stiffness and increased scarring? And interestingly, I think what we also realized that with the heavy water work, that we had the window of opportunity to actually, it wasn't all done. It wasn't, it doesn't turn over, so you have to wait for a new event. It's turning over. It's dynamic. And that dynamism of the dermal turnover gives us therapeutic opportunity. And so with Pharmaxis, now Syntara, a pharmacology company in Sydney, we've worked right from the bench to the bedside in this program. And I'd like to share it with you because it was something Mark was very proud of, because he had driven it from the first collaborative discussions around the LOX inhibition, and this, our first toe in the water, looking at the bench work was the PXS64, and looking at cells, and we can see we've got untreated cells and treated with TGF-beta, the pathway that we know stimulates that collagen formation and that scar type of collagen, and we're looking looking at different concentrations of PX64 to try and understand how much we need and whether it actually will have the significant impact on the whole collagen deposition. And clearly you can see there is a difference. And then looking at the scar in a jar, that's a standard process we use, where we've put the cells in a jar, whether they be keloid cells, fibroblasts from different origins, and we then crowd the cells, put TGF-beta, and then culture over a few days, and we look at the collagen production and the orientation. And so you can see that when we've got, again, a LOX inhibitor in this space, we can see that it influences the production of collagen and decreasing the deposition and changes the configuration of that collagen. And so we thought we're onto something really exciting and interesting here. And so then we go into our first large animal model, and the team are just amazing, like Andy massaging cream on the pigs every day and so forth. And so we made wounds. We looked at the pigs over time, and we're looking at the amount of LOX inhibition, the impact at the cellular level, at the histological level. And we can see that there, and of course the macroscopic scar, and we can see that that is having a significant influence. So we've now got we've got the basic science from the benchtop in the cells, we've got the large animal model, and then we went into the first in human. And looking at what dose do we need, how are we going to understand that? And so with the first group was normal adult male volunteers. And so we looked at a series of application of the LOX inhibitor with biopsies, looking at the concentration in the skin construct, and then gave us the information for us then to go into the second phase of the trial, where we decided how much we were going to use, and then again taking the bloods and the biopsies over time. And we could see that there was a significant dosage of LOX inhibition, and so we were able to see that it was effective in that skin construct. And so then we go into the randomized control trial. And in the randomized control trial, with the primary outcome was POSAS, and it showed no difference. And so that was a little disappointing. However, this was at 3 months, and a number of our patients kept saying, oh, it's gotten much better, it's gotten much better. And so even though it's anecdotal, it's off trial, there was continued improvement over time. And it wasn't just the only thing we measured, of course. We measured lots of secondary outcomes. And so taking you through this, where you can see we've got the cohort, the placebo, the active agent. We can see that it's actually is active in the skin. We see the POSAS doesn't make any difference, but we start to see some of our other mechanisms with our OCT have demonstrated quite significant differences in the underlying extracellular matrix of that scar. And so just taking you a little bit more detail into looking at the OCT measurements over time, and you can see all the active ingredient and the red, and the placebo is the blue, and we can see there is significant difference in the vasculature framework that is more like a normal skin extracellular matrix framework, moving it to the unscarring the scar kind of space over time. And so that led us on to there's another trial that's ongoing with another group looking at cardiothoracic scars with what we've learned in this. But also we did have an element of erythema. The LOX inhibitor has been reformulated, and we went on into keloid scars, which I will come back to in a second. And so when I think about all this, and I've just presented just a little bit of the tip of the iceberg of almost 20 years' work, you can imagine I know I talk quick and I'm really enthusiastic, but I just can't tell you enough of all the work that has been done. But I would also wanted to spend a little bit of time about looking at the future and really stimulating ideas and stimulating and poking the bear, if you like. So diagnosis of keloid, we have got to nail this. And whether it is methylation patterns to begin with, whether it is skin chemistry, we've got to make an accurate diagnosis. And so that's worthy of endeavour. The keloid, LOX inhibition in the keloid is, we're 14 patients in and on hold at the moment because we saw an unacceptable level of erythema. And so we've held, but we're tracking them over a year because we saw in our non-keloid population how they continued to get better. And we have coming down the pipe an alternate formulation that's been designed specifically to reduce the inflammation. It is really interesting. Do we need an inflammation to actually stimulate a response? Clearly we do in laser. And is that something we need to modulate or something we need to accept? And I don't know yet. Because it is important that we make sure that we do no harm. One of the things that was always on the table for discussion is whether this is systemic or non-systemic. And looking at fibroblast activation protein PET scans, I think is really interesting. I am desperate to get the funding to do this, because this is a way of highlighting fibroblasts across the body. So will we be able to see how that fibrosis on the skin that we see in our patients with, in my case, that I see much more frequently is burn scarring or keloids, which I see less frequently in my environment, but what's happening on the inside? I can tell you categorically that a non-major burn injury in those that are vulnerable changes their life trajectory with an increased risk of cardiovascular disease, neurodegeneration, cancer, diabetes, infection, wherever you look. That traumatic episode changes the life trajectory. There has to be something underneath. And so we're chasing the funds to do that. Understanding turnover beyond just the rudimentary place we've done with the collagens. We're now looking at, in our animal models, we're trying to understand the broader range of turnover of the extracellular matrix. Again, looking for the opportunities for targeting intervention and understanding how long we need to use that intervention. So that's information that is really important. Understanding the pathways that drive that systemic treatment from keloid disease, it has to be a level of systemic. And I know we see small manifestations, but I see small burns that 80% of our pediatric cases have no visible scar. Yet we have upwards of 60% of them have vaccine amnesia and don't respond to their vaccines later on. We see lipidomic profiles that are similar to cardiovascular disease in the under 3s. So I think this whole disease is systemic, but understanding the manifestation and understanding the immune response is really pivotal in developing therapies going forwards. And I've been very impressed with the dermatology space, looking at things like hidradenitis suppurativa treated with immunotherapy. That is something as a surgeon, as a plastic surgeon, was the most deforming surgery I would ever have the misfortune to have to do. And now it's taken off the table. So I can't emphasize enough, or too much I should say, the power of the science behind what we do. And so one conversation that I have with Mark on a regular basis was, well, if we understood the immune response, could we vaccinate against post-bat scars? You know, can we actually vaccinate against post-scar outcome? Now, maybe some smart youngster in the crowd will take that, run with it, and actually develop it because, you know, is it related to stimulation of inflammation of viruses? You know, HPV, where does that sit in this whole spectrum? I have no idea, but I have no idea how to heal in space. And I was asked that question recently. And well, I don't know, I've never been. But anyway, and so where does this all take us? I've taken this from a talk that Andy and Lucy, our two senior scientists, did in Mark's absence. It's how to do good science. He teaches all the youngsters how to do good science. And this was one slide, as I was looking at this last night, I just lifted from their talk because I thought, yeah. Mark found his tribe here. He was dead squeamish, refused to come into theatre, but he was desperately focused on changing people's lives for the better. And he came here and he found his tribe. And, you know, when you look at this, say yes, do stuff, link in, blinkers off, have an open mind, and have a zero tolerance to bullshit. Mark all over. And I'd like to share with you some videos taken here. I wonder who Mark's having a chat, bending. It looks like Mark's having his ears bent there seriously by Lamont. Yeah.
Where was that?
Rome. And this is Montpellier. I think we enjoyed enormously our trips to Montpellier as well. Yeah, I think that was when we first connected with the group. Again, in Montpellier. And Mark with the boss. Oh, sorry. All right. And so I'll leave you with the last conversations I had with Mark. We were in June of last year, we were in Edinburgh at the meeting which took me to this instead of with you guys in Shanghai, and Mark came via Shanghai. Beyond the standard unconventional vertebrate models for biomedicine, we were there because of this little fella, the spiny mouse. Absolutely fascinating little critter. It's the only mammal known to regenerate. We're working very hard with collaborators in Edinburgh and Kentucky, trying to understand how we can use that information and that knowledge to change the paradigm that we deal with. But as Mark and I were sitting there kind of zoning out a little bit because it was pretty heavy science, and I was kind of, I felt like my brain was splattered against the wall. One of the speakers stood up in a very unassuming way and started talking about hibernation. And as the talk went on, Mark and I were leaning further and further and further forward. Why we never thought about this before? How can mammals sleep for 3 months and not produce urine but not get renal failure? How can they sleep for 3 months and wake up without osteoporosis and sarcopenia? How can they sleep for 3 months and maintain their cutaneous integrity? My goodness, we've got a lot to learn from these creatures. And that was about the last conversation I had. And so we've had the privilege of working with an extraordinary scientist, an extraordinary person. He was many things to many people. Husband, father, friend, scientist, colleague, collaborator, mentor. Always maintain that curiosity, but the focus and integrity. Good science is what it's about. Always making sure that you've got the frameworks around, the rigor around it to make that data worth standing up and talking about. And we all miss him dearly. I can't begin to acknowledge everyone, but I think this network, this map that's on Mark's repository in the university just begins to show the extent of collaboration over this almost 20 years. And please, I've left the link there so that you can go and look and see the publications and see your own names in some part there with the collaborations from recent or the past. And I'd just like to close by thanking the Society for honouring Mark in this way. And thank you for giving me the privilege of delivering this first Mark Fear lecture. And I really sincerely hope that some of the work that I've presented will spark an interest in somebody somewhere, and somehow we will get the answer to reduce the suffering, and Mark would then rest easy. Thank you.
Well, thank you. I know. Thank you very much for doing this. We dearly miss Mark, and I would have loved to see him here. Having said that, his legacy will continue, and Keloid Research Foundation has always appreciated, we have appreciated him, I have appreciated him. He has been present with us every time we had a meeting, and his legacy will continue here. This lectureship will continue year after year after year, and we would love to have other presenters from your group, from other groups, to take on the challenge of presenting a lecture at this level, at this caliber, next year, future years. I'm going to stop here and ask the audience if you have any questions for Professor Wood.
Professor, you seem to...
Wait a second, please.
Firstly, thank you for thanks for the wonderful, wonderful lecture. Brought tears to my eyes. With hibernation, of course, if you and I fall in frozen water, we freeze and survive. Even after 30 minutes, everything shuts down. It's very interesting. How do you explain that?
One, I would have to, number one, I would have to interrogate the veracity of the claim. And is that, is that true? Is that true of everybody? Is that true in certain circumstances, age, etc., makes a difference? I know stress responses are different in male and female as well, and things like that. But then I think I have no explanation. But one of the things that I've written in my book for Michael is we harvest cells routinely. And routinely, we freeze them. And then we thaw them out, and we do experiments on them, and then we freeze them again. And so I think the answer to your question is just at the edge of our fingertips, and we've just not looked. And so one of my things to explore is the difference in the transcriptomics and the expressions of the pathways in our fresh tissue versus our frozen and thawed tissue, because that may help answer your question.
I have a question. You had described that there was a bit of an unexpected delayed response from the LOX inhibitor. But was this based on your and Mark's work with the heavy water turnover experiments?
No, we haven't. We didn't extend. That's an interesting one, because we didn't extend the heavy water experiment long enough. So we can't answer that. But we saw the implication is that the turnover of a proportion of the extracellular matrix occurs every 3 months. So the implication is that if we have changed the extracellular matrix stiffness by the LOX inhibition and reduced the stiffness, then over time, the driver of the phenotype of the fibroblast regenerative versus fibrotic is changed. And so we're moving to a less fibrotic phenotype within the construct. That is our assumption, but that's what we're trying to prove.
Yeah. Thank you.
Any other question?
Yeah.
Go ahead.
I'd like to make a comment, not on the presentation. This is to the founder, chairman, KRF, Dr. Michael. See, we lost 2 past members, and Dr. Mark is also a significant person. So my suggestion is, back home, what we will do is, like, the valuable past members, we will create an oration in their name. And we will make the younger researchers or the clinicians to present in that oration. And we will choose one best presenter paper and we'll give them a memento or a shield or something in the name of a past member. So the country which is organizing, it's your responsibility, the important key members of the KRF, it is your responsibility to organize that funds. And I'm sure it's not going to be more. It's like in dollars, it's going to be just 20 or $30. That's it. Max $30, you can get a sheet or shield something. And it will be a good way of honoring our past members. This is my suggestion.
Thank you very much. Wonderful suggestion. Questions, Professor Deng?
Thank you very much, Professor Wood, for your very interesting and moving presentation. And yeah, indeed, it's very important, better understanding of the pathogenesis of keloid, pathogenesis of uttermost importance. I was wondering, do you think that the epithelial integrity disruption of the tight junction is a primary reason for keloid etiology? Or may the disruption also be secondary to the keloid growing bigger from the reticular dermis underneath the epidermis?
I think if I can't 100% answer that with accuracy, but I would suggest it's a secondary because you've already got some changes that have had to occur in order for the cells to behave that way. I think, therefore, when we see occlusion, softening, like the Brazilian team have represented that very nicely, softening with occlusion, it's been talked about. I think that's why we see an element of change in that regard, but it's certainly not curative. Mm-hmm. So I would be sitting on the side of the fence that the loss of tight junctions and that lack of epidermal integrity is really a secondary phenomena, one that we pay attention to. We can help our therapeutic model of care, but it's not curative.
Mm-hmm. It would also be very interesting to have biopsies or histological data from keloids in different maturation stages, from very early keloids to burned out keloids, so you can see the process.
Yes, I think that's one of the things that I think is really interesting, is trying to relate the skin surface chemistry with the underlying cellular functionality, because then we've got access. And then things like OCT, we can image, and we can image at sort of a quasi-histological level. Well, it's not quasi, it is at that sort of level. And so if we can look at our patients regularly, whether during that post-intensive treatment phase, when we're watching for recurrence, then I think that would be where we can get information. But if we take punch biopsies, that becomes difficult because we're causing the trauma.
Yes.
So I think it's an interesting challenge that faces us.
Mm-hmm.
He looked at the brain cells with great interest. He was a brain specialist. I'm asking you, there's lovely pictures of the blood vessels. Are those EM?
No, they're OCT, optical coherence tomography.
And then, as I'm a bit hard of hearing, was I correct in understanding that if you have a small burn, you can affect your whole life?
Yes.
And die of cardiovascular disease, diabetes, and many other things, all due to a little burn?
Yes, it's a piece of work we did with data linkage. We looked at 34,000 patients with burn injury and 120,000 comparators with respect to age, sex, geospatial and socioeconomic factors. And we discovered that there is an increase in the diseases of aging. And what the surprising thing was, we were looking for a correlation between the impact over life with the extent of injury. And we did not find that. So there's other things at play. And if I cut the data through at 15 years of age, I would see the unexpected deaths, a third are infection, a third are cancer, and a third are other injuries. If I cut the data through at 65, the unexpected deaths are related to cardiovascular disease, 60%, and then neurological degenerative diseases, cancer, and then odds and bits and pieces. So yes, a burn injury, an inflammatory traumatic episode, impacts your life trajectory. And I think that goes for not just burn injury, I think that goes for many things in a vulnerable individual. So we're trying to find out what makes someone vulnerable. And I think that is a very important space that we're working in right here, because what makes people vulnerable to keloid disease? We don't know. There's some, there's genetic aspects, there's environmental aspects and things like that, but we really don't know, yeah? And what impact does it have on the rest of life? Again, something that we need to investigate.
Are there any other questions for Professor Wood? Yes.
Maybe just a very short comment on this. We know from many skin diseases, especially like psoriasis, that this goes along with a higher risk of cardiovascular comorbidity. So it's the same, that inflammation in the skin does impact the rest of the other part of the body.
Yeah, I'm working with the dermatologist, Chris, from St. Thomas's, I can't remember his name. Exactly that. It's that inflammatory, the cutaneous inflammatory pathologies, I think really could, by working together, whether it be psoriasis, EB, and all the different manifestations that are driven by inflammation or drive inflammation in this space, could help us, because then we start to build the body, the breadth of knowledge by looking at what's different between these different pathologies and what's the same. Yeah.
I sometimes wonder if it's just a predisposition for inflammation. So it may not be the skin influencing the cardiovascular system, but it may already be there.
Yeah, there's absolutely a vulnerability, but it's trying to find what triggers that vulnerability and what the basis is that's important. Yeah.
I'm going to present one of the questions from Zoom attendees to Professor Wood. The question is, why don't more of our patients with deep dermal or full thickness burns develop keloid scar? Why are hypertrophic scars the norm?
I think burn injury is more common than keloid disease. And I think I see hypertrophic scars more frequently than I see keloid scars. But in someone who has got a keloid scar tendency and they get bent, they will get keloids. And so I think it's a bit of a numbers game. And I also think it's related to the treatment models of care around burn injury. We're very, very focused on rapid epithelialization and whether it be cell spray or the skin grafts or the dermal templates, we're very focused on getting that burn removed and getting it replaced. And I think that's changed the hypertrophic scar paradigm. And I think most of the time, historically, what would have been classed with conservative, old-fashioned treatment, if you like, for burns, historically, when they said, oh, there's a keloid, I think it would probably have been hypertrophic. Yeah.
Thank you so much. On a follow-up to this, a few years ago when I visited Dr. Caceres's burn center, and again, I'm not a burn surgeon, I have no experience in burn, we saw a few patients, young children actually, who were prone genetically to keloids. They had the other keloids, and they had very minor burns that had turned into keloids. You could see just tiny 2 millimeter spot of burning that had turned into keloid at the back of their hands. So perhaps there has to be that genetic propensity to develop keloids, to form a keloid secondary to a burn injury, as opposed to someone who is genetically not prone to form keloids and then obviously have a burn injury.
Absolutely. As I say, I think it's just the prevalence incidence situation. Yeah.
Albert, please. And then Professor Deng.
Yeah, hello. So I think we haven't looked really systematically into the potential associations with keloids. And it seems a bit strange that there wouldn't be. I mean, I found one study from gastroenterology where they looked at the risk for having strictures after surgery, after esophageal cancer, and where they created an anastomosis, and they looked at hypertrophic scarring keloids together, and they found an odds ratio of more than 300, increasing the risk for getting this complication. So maybe but that's the literature of a different specialism that isn't here. So probably we haven't looked really into the associations yet.
I think maybe in a time where that can possibly be made doable, because we've got machine learning. I mean, when you start to think of it, keeping up with the literature in what we do, right, is massive, isn't it? It's overwhelming these days. And when you start to go into looking at literature from other specialties, it's impossible. But with machine learning, I think this is the absolute use case for it. Is that let's see what the fibrosis and the manifestations of abnormal fibrosis, whether it be the liver, whether it be peritoneal adhesions, whether it be sort of stenosis around the esophagus or whatever, and start to actually build those associations. I think you're absolutely right. But I think now it's doable for some special young maths whiz, sort of some AI whiz around there. Yeah.
Thank you so much. Professor Deng.
Yeah. I just want to say thank you, Fiona. I thought you will present your ReCell because I always we met a long time ago. We talked about the regeneration of skin defect. Use ReCell. It's really very great invention. But today you show us a lot of very basic research, which is very close to the clinical treatment. So I just want to say thank you to you. Thank you.
Thank you very much. I think it is interesting because what brought us here in Montpellier all those years ago and trying to understand abnormal fibrosis was the fact that we were getting really good results with our ReCell where we were putting it. But we needed to integrate it around with the normal skin and not have a scar underneath it. So that's why we got into trying to understand the basic science of fibrosis and scarring, because we wanted our ReCell to actually integrate seamlessly into the tissue construct around. So in order to do that, you have to understand fibrosis and scarring.
Thank you very much. And you thank Professor Veer. I also thank you on behalf of everyone for taking the trouble of traveling all the way from Australia to here to be with us today. And we truly, truly, sincerely thank you for everything you have.
Thank you.
Thank you.
So with our sympathetic collective memory of Mark, we would, on the behalf of KRF, would like to present you with the first annual Mark Fear, visiting professorship and lectureship.
Also, Gertrude will send it home.
Thank you very much. Thank you. Thank you very much.
Thank you.
So we have to make a change in the schedule of the program. Next was my dear friend, Frank Neeson's talk. However, we had scheduled patients to come in at 11:45. So we're going to do that patient session now. And then after that, we perhaps take a break for lunch and then we come back and do your presentation or whatever, however things would evolve. Thank you so much. Yeah, please bring the patients in.